I'm Lynn Foldswood. I used to present the Watchdog programme, and 15 years ago I was a St Mark's patient with advanced bowel cancer. I've just had a virtual colonoscopy, and today I got the all clear. This DVD is a practical guide for health professionals who perform or who'd like to perform virtual colonoscopy examinations in clinical practice. The St Mark's team provide practical tips and tricks of the trade covering the entire patient journey. I hope you find them useful for your own service.
At St Mark's, all patients receive an information booklet and DVD prior to attending their appointment. This information explains what the test involves, how it is carried out, what to expect, and the risk involved. This will enable the patient to help make a decision if a virtual colonoscopy is the right test for them. This information is available at the St Mark's website. There are several methods used to prepare the bowel for a virtual colonoscopy, including standard laxative regime such as sodium picosulfate shown here. In addition, more recently, there have been fecal tagging agents which are designed to label the residual feces or fluid with dense materials that show up easily on CT scans. For example, barium products or liquid iodine products. These can be used in combination with reduced laxative row scheme, for example, senna granules, to improve the patient experience. In addition to using laxative and tagging row scheme, you should provide a diet sheet with details of which foods that can and cannot be used, with examples available from major supermarkets, depending on their dietary habits. This information is also available from the St Mark's website.
We're all encouraged to eat high fibre foods these days because they're better for our bodies, but to clear out our insides for this test, we're asked to eat low fibre foods. That's white pasta, bread, rice, eggs, chicken, white fish. You can have chocolate, but the day before, after breakfast, you only have non-solids. That's ice cream, jelly, clear soups, fruit juice, that sort of thing. These lovely foods are high fibre and indigestible, like mushrooms and sweet corn, veg, red meat, baked beans, wholemeal bread, wholemeal pasta, high fibre and harder for the body to digest.
The appointment letter should clearly explain where the patient should attend for the virtual colonoscopy. Having undergone bowel preparation, toilet facilities should be made available for the patient. And ideally, virtual colonoscopy should be performed in a dedicated list, perhaps at the beginning of the day. Written consent is routinely obtained from patients by the St Mark's team to cover the standard virtual colonoscopy examination and also patient data for teaching and audit purpose. In order to optimize subsequent interpretation accuracy, the patient is encouraged to visit the toilet one last time to evacuate any residual material from the rectum and lower sigmoid colon. Patients are escorted to the scanner room, then asked to lie on their back on the scanner table. At this time, the radiographer makes a visual assessment of the patient to determine any need to modify the scan parameter according to patient body mass index.
For example, the radiation dose should be increased if the patient is markedly obese for at least one of the scan acquisitions,
which will be subsequently used for extra colonic review. CT scanner rooms can often be an intimidating environment to patients. Therefore, friendly conversation with the reassurance that the patient's face will not enter the scanner field and that scans will generally only last a few seconds. This will help to reduce anxiety, particularly for patients who are claustrophobic or who have respiratory difficulties. At this point of the examination, the St Mark's team will routinely administer 20 milligrams of buscopan intravenously through an orange needle, which has been shown to significantly improve colonic distension. Buscopan is particularly helpful to patients with diapaticollosis, found more commonly in the older patient population. Whilst evidence supports the use of buscopan in this setting, several institutions which produce very high quality examinations, particularly in the asymmetric screening population, do not use an intravenous spasmetic. In the USA, buscopan is not licensed. It is noteworthy that glucagon, which is often used as an alternative when buscopan
Is
is
contraindicated.
for barium enema, has been shown to offer little benefit for colonic distension during virtual colonoscopy. When intravenous contrast is used for virtual colonoscopy, the buscopan can be administered through the intravenous cannula. The use of intravenously administered contrast will be determined on an individual patient basis. Evidence shows the use of contrast offers very little toward improved detection of colonic
Polyps.
However, it may help detection and subsequent characterization of extra abnormalities. The decision whether to use intravenous contrast routinely will vary between centers and is based on a judgment of whether its potential benefit outweighs the financial cost, detrimental effects of clinical workflow, and potential for allergic reactions. At St. Mark's, intravenous contrast is not routinely administered unless the referring clinician has found a probable abnormal pelvic mass or the patient is already known to have cancer. Following administration of buscopan, a thin rectal catheter is inserted. However, it is probably safer to use a thin, flexible tube, such as a Foley catheter. Unsurprisingly, patients prefer the thinner catheter. Anecdotally, the use of standard rigid catheters was frequently cited as the most uncomfortable aspect of the examination during the early development of virtual colonoscopy technique. In addition, research has shown the use of thinner catheters have no detrimental effect. At St. Mark's, we use a dedicated thin rectal balloon catheter attached by plastic tubing to an automated colonic insufflation device. This also has an inflated balloon with a capacity of 30 mils, which can be used to retain the catheter within the rectum. While the use of balloon catheter is a little controversial as a result of increased risk of perforation associated with barium enema in the past, the newer catheters have smaller balloons, and providing practitioners are well trained, the risk appears to be much smaller. There is a blue mark on the tube which is located 4 centimeters below the lower limit of the balloon, which corresponds to the approximate length of the anal canals. To ensure the entire balloon is appropriately placed in the distal rectum prior to inflation, this blue line should not be visible. The catheter should be inserted so that the blue line lies within the distal canal, approximately 1 centimeter from the anal opening. The automated insufflation machine is designed to be used with carbon dioxide, although air can be used. Once the catheter is safely inserted, the green start button is pressed to start insufflations. In order to facilitate the passage of gas, the patient should be lying on their left side. Members of the St. Mark's team keep an eye on the patient's facial expressions to detect any discomfort early. Patients find carbon dioxide more comfortable than air, and carbon dioxide is more rapidly absorbed by the colonic echosa. Also, if a same-day colonoscopy is organized, then a collapsed colon is easier to navigate with an endoscope. After approximately 1.5 liters of carbon dioxide have been introduced, the patient is repositioned, so they are
supine.
Insufflation continues until approximately 2 to 3 liters of gas have insufflated, by which time the colon is usually full. When full, we often recognize the pressure within the rectum builds and exceeds 25 millimeters of mercury. This pressure, which is measured at the rectal catheter, is displayed on the front of the device. A safety cutout mechanism will stop further insufflations until the rectal pressure drops below 25 millimeters of mercury. This point often represents where the colon is full and the
ileocecal valve
remains competent. The volume of gas administered is also displayed on the top left of the machine. This should not be used in isolation to judge when colonic distension is optimal. Occasionally, patients will require up to 12 litres of gas to achieve good distension, particularly when there is
the ileocecal
valve incompetence and reflux of gas into the small bowel, or if patients have anal incontinence to gas. Patients will frequently complain of discomfort and bloating while the colon is distended in the supine position. But generally this improves when turned prone. This needs to be explained to patients before the examination, after which most patients will tolerate mild discomfort or bloating. The ultimate device has a shut-off mechanism when 4 litres of gas have been insufflated and every 2 litres thereafter. When insufflation is paused in this way, the green start button needs to be repressed to continue insufflation. The patient is then taken into the scanner for an initial scan acquisition. We have a low threshold for performing the scout if we have difficulty insufflating the colon, or only a small volume of gas can be administered. We perform a scout at this time to exclude a distal obstructing mass or perhaps an obstructing hernia. The quality of colonic distension can sometimes be difficult to judge on the scout image alone. For example, this scout image which has been transferred to a workstation. You can rotate the image to see a focal area of spasm which is not apparent on the original view. Experience will help the practitioner to determine the quality of distension from these images. Once distension has been assessed and adequate using these parameters described before, the supine acquisition is planned and performed. The use of multi-text scanners have revolutionized virtual colonoscopy, not least due to the short scan acquisition times, enabling most patients to hold their breath through the scan. For example, this 64-slide scanner has acquired all the images within 6 seconds. Once the radiographer has determined that all the colon has been included in the initial scan, the prone scan can be performed. At least one of the scan acquisitions should include the entire liver for subsequent extracolonic review. As mentioned before, patients often feel more comfortable when turned prone. A repeat scout is performed with the patient in the prone position in order to maintain adequate distension. It is also possible, if a cancer has been seen on the initial supine acquisition, to intervene at this time and insert intravenous cannula for administration of intravenous contrast as part of a staging scan. Given that the risk of radiation is much less of a concern when a patient has cancer, it is not unreasonable to perform a subsequent standard abdominal pelvic CT scan with intravenous contrast for staging. Following the prone acquisition, the rectal catheter can be removed. The patient is then escorted back to the changing rooms. Patients will appreciate a cup of tea and a biscuit after the examination, particularly as they've been starving overnight. At this time, the practitioner can transfer the data to the workstation for subsequent interpretation. At St. Mark's, there is the facility for a same-day colonoscopy. Therefore, scans are reviewed within 2 hours. Choice of workstation and interpretation method will depend on several factors, including the software accompanying the scanner hardware, also the training and experience of the interpreting practitioner. Undoubtedly, there is a marked variability in reader performance in both the UK and elsewhere. All experts in the field strongly recommend that practitioners who wish to report virtual colonoscopy examinations undergo a recognised form of training prior to independent reporting.
Providing practitioners are adequately trained and standardised protocols are followed, then the technique of virtual colonoscopy is relatively easy to perform, and very high quality examinations in terms of bowel preparation and distension can be achieved. However, reader performance is variable and therefore dedicated training on interpretation is required. The St Mark's course brings together both radiographers and radiologists to learn about implementation and the practical techniques of virtual colonoscopy examination and interpretation. We encourage a team-like approach which works alongside endoscopy for the benefit of patients.
The success of virtual colonoscopy to existing techniques is likely a consequence of improved patient experience, and therefore the opinion of patients undergoing the technique will soon influence the number of patients referred to your service. The following details of conversation between Lynn and another patient who has undergone virtual colonoscopy, describing their experience, are included in the patient DVD that can be obtained from the St Mark's Virtual Colonoscopy team. More details are available on the website. Lynn is talking to another patient who has just undergone a virtual colonoscopy examination.
Well, we're just recovering after our virtual thingies, and how was it for you, Franny?
Not as bad as I thought, Lynn. The prep wasn't really very nice, but not too bad because I kept to a good diet beforehand. Colonoscopy itself, it wasn't very nice when they put the gas in, but that only lasted a couple of minutes. But once I turned over to lie on my tummy, it wasn't too bad at all.
What did it feel like at its worst?
It kind of felt like I was full of wind and a bit colicky.
A little bit painful.
A little bit painful, just more uncomfortable than painful, yes. But it didn't last too long, 2 or 3 minutes.
Yeah, I didn't like the prep much either. Prep's no fun, and I felt it was a little bit like painful pins and needles when the air went in, and it's left me with a little bit of tenderness afterwards. How about you in this area?
Not too bad, no pins and needles, but if I push, I know that something's happened in there,
Yeah.
you know.
The good thing about it, that I've had an MRI as well, and unlike MRI, you can move around. You don't have to lie there
That's
frozen
right.
still.
Yes.
Marks out of 10. It wasn't bad at all, was it?
It wasn't bad, not
No.
as bad as I thought it was going to be,
Yeah.
really.
And if you've got to look in my insides, I'll have another of those. Thank you.
Me too.